Imagine a woman going into labor 200 years ago. There is no ambulance on the way, no blood bank, no antibiotics, no operating theater waiting behind a pair of doors. The people around her may be experienced, calm, and deeply knowledgeable. But if the bleeding does not stop, if the baby cannot pass, or if fever begins a few days later, experience may not be enough. For most of human history, childbirth stood at the border between an ordinary family event and a medical emergency. The same room could hold celebration in 1 hour and mourning in the next. So why were pregnancy and childbirth once so dangerous? And what changed so dramatically that, in many parts of the world, deaths once accepted as fate became rare? The first difficulty is that the deeper we travel into the past, the less reliable the numbers become. Ancient societies did not keep modern birth certificates, hospital records, or standardized causes of death. A woman who died after labor might be described as having died from fever, weakness, bleeding, or simply in childbed. Archaeology can occasionally reveal a mother and baby who died during an obstructed birth, but discoveries of this kind are rare. Historians must therefore work with scattered evidence, medical writings, parish registers, family letters, cemetery records, and the first national statistics. What those records show is sobering. In several European countries during the 19th century, roughly 500 to 1,000 women died for every 100,000 births. That was approximately one maternal death for every 100 to 200 deliveries. Most women survived an individual birth. But women often experienced pregnancy many times. A danger that appears small when faced once becomes much greater when repeated across an entire lifetime. People in the past were not unaware of this danger. Families knew it. Midwives knew it. Pregnant women knew it. Childbirth was expected, but it was never treated as trivial. For much of history, birth took place at home, surrounded by women. Midwives were among the oldest kinds of skilled practitioners. Their knowledge was learned through apprenticeship and experience, how to recognize the stages of labor, how to support and position the mother, and how to identify signs that something was going wrong. From ancient Rome to medieval Islamic societies and early modern Europe, midwives were not merely attendants. They were trusted specialists whose knowledge had often been passed from one generation to another. This matters because the story is sometimes told too simply as though women in the past were completely helpless until male doctors and hospitals arrived. That is not accurate. Experienced birth attendants could manage many normal deliveries successfully. Familiar women also provided physical assistance, practical knowledge, reassurance, food, warmth, and emotional support. But there was a hard limit to what experience alone could achieve. A midwife might recognize severe bleeding, an obstructed labor, convulsions, or infection. But she could not summon stored blood, perform a safe emergency operation, or administer an effective antibiotic. The central problem was not the absence of courage or knowledge. It was the absence of rescue. The greatest threats were not mysterious. They are still among the leading causes of maternal death today: severe bleeding, infection, dangerously high blood pressure, and complications during labor. The first danger was hemorrhage. After the baby is born, the uterus must contract firmly enough to close the blood vessels that supplied the placenta. If that does not happen, a healthy woman can lose a fatal amount of blood within hours, or even more quickly. In a modern hospital, medicines can help the uterus contract. Clinicians can replace lost blood, locate the source of the bleeding, and perform surgery when necessary. In the past, there was no blood bank in the next room. Once the body's blood supply was gone, there was often no way to restore it. The second danger was obstructed labor. A baby might be positioned badly. The mother's pelvis might not allow the birth to proceed safely. Labor could continue for many hours or even days, exhausting the mother and threatening both lives. Today, an emergency cesarean section can bypass the obstruction. Historically, surgery on a living mother was so dangerous that it could not be considered a dependable rescue. Even when an operation was completed, blood loss and infection could still kill her. The third danger was eclampsia. A pregnant woman might develop swelling, severe headaches, visual disturbances, or dangerously high blood pressure. She could then suddenly suffer seizures. Before blood pressure monitoring and effective treatment, this transformation could appear almost supernatural. One moment, a woman was speaking. The next, her entire body was in violent convulsion. Modern prenatal care can often detect the warning signs earlier. Treatment can then reduce the risk that pre-eclampsia will progress into life-threatening eclampsia. The fourth danger was infection. This was especially cruel because the birth might initially appear to have gone well. The baby was alive, the mother was awake, the family relaxed. Then, over the following days, fever arrived. The mother became weak, confused, and desperately ill. This was childbed fever, also known as puerperal sepsis, an infection that could spread through the body after delivery. And during the 19th century, the place intended to make childbirth safer sometimes made infection worse. At Vienna General Hospital in the 1840s, two maternity clinics existed side by side. One clinic was used to train doctors and medical students. The other was used to train midwives. Women feared the doctor's clinic because its death rate was far higher. The physician Ignaz Semmelweis studied the difference. Medical students frequently moved from dissecting corpses to examining women in labor without properly disinfecting their hands. The midwives did not perform those autopsies. Semmelweis began to suspect that the doctors themselves were carrying the cause of the disease from the dead to the living. He ordered medical staff to disinfect their hands with a chlorine solution before examining patients. The number of deaths fell dramatically. Today, this sounds obvious. At the time, it was revolutionary. Germ theory had not yet been fully established, and many doctors resisted the suggestion that their own hands were killing patients. Semmelweis possessed evidence, but evidence does not always defeat pride quickly. His story marks an important turning point. Childbirth did not become safer merely because it moved into hospitals. It became safer when hospitals learned cleanliness, antisepsis, careful measurement, and accountability. There was no single moment when childbirth suddenly became safe. The transformation came through a chain of developments, each solving a different part of the problem. Antiseptic and aseptic practices reduced the spread of infection. Blood transfusion gave doctors a way to replace what hemorrhage had taken. Antibiotics transformed many deadly postpartum infections into treatable illnesses. Improvements in surgery made cesarean delivery a genuine rescue for obstructed labor rather than only a final desperate act. Medicines helped control bleeding after birth. Blood pressure monitoring made pre-eclampsia easier to recognize. Skilled obstetric teams learned to prepare for complications before the patient collapsed.